안녕하세요. 서울 뿌리 깊은 치과의 조영진 원장입니다.
Greetings, I'm Dr. Cho Young-jin of Deep Rooted Soul Dental Clinic. Today I'm going to talk about loading protocol for implant prosthesis. First, I'm going to talk about types of implant loading, loading protocols of implant prosthesis, and decision of loading timing.
결정에 대해서 말씀을 드리도록 하겠습니다.
First, I'm going to talk about types of implant loading. If you look at the consensus statement report from 2013 ITI Consensus Conference, loading implant within a week since implant placement is referred to as immediate loading. Early loading refers to applying loading between 1 week and 8 weeks. Doing loading after 2 months is referred to as conventional loading. In the past, in the lower, you had to wait 3 months, and for the upper, you had to wait 6 months. To do conventional loading, that was the principle. Recently, with the advancement in technology, the loading period is shortened. After placing the implant, if you look at the remodeling process, first the platelet or macrophage cells show histological process, and up to second week there's revascularization. From 4th week to 6th week, phase 1 bone regeneration, woven bone formation is made. Phase 2 bone regeneration is when a lamellar bone is formed. Although it differs by patient, by week 16, 70% of lamellar bone is formed. This is the evidence for conventional loading where we had to wait 3 or 4 months for loading. Before 2000s, in 1980s and 90s, in fully edentulous patients, we provided fixed hybrid restorations. If you look at the clinical order, implants would be placed in the fully edentulous ridge, cover screw would be connected, and it will be submerged subgingivally. You have 3 months of healing period, and after that, as shown in this image, fixed removable prosthesis is provided to the patient. In the past, conventional loading was done. This is the traditional way of providing implant restorations. After implant is placed, when to apply loading. In determining the timing, you need to understand the implant stability graph. Once implant is placed and primary stability is achieved, the mechanic and physical fixation of the implant to the bone is referred to as primary stability. Primary stability goes down due to bone remodeling. Osseointegration, which is biologic stability, the second stability gradually increases as of implant placement. If you add these two, this is total implant stability, which is combination of primary stability and secondary stability. If you look at this graph, during a certain period, total implant stability dips and then increases. This is called a stability dip. This dip is affected by how we place the implant and what kind of quality bone. Depending on whether it is soft, normal, or hard bone, it may differ. If the bone quality is good, primary stability will be good, and stability dip will be less. Stability dip, depending on how high it is compared with loading stability and how long it stays low before it comes back, it may differ depending on bone quality, but this can be used as a criteria. From machined surface, RBM surface, to bioactive surface. Depending on implant surface, loading timing can change. If there's no difference in primary stability, if you look at RBM surface on the left and hydrophilic surface on the right, you can see that there is a difference in inclination of secondary stability. If you use biologic hydrophilic surface, the inclination of secondary stability goes up and a stability dip becomes much shallower and occurs sooner.
앞쪽으로 당겨지는 것을 그래프에서 확인하실 수가 있습니다.
As different surfaces became developed, including RBM, SA, and CA, the stability dip period where it falls below loading stability becomes much reduced, and therefore the loading period becomes faster.
로딩 타이밍은 자연스럽게 앞으로 당겨지게 된다고 할 수가 있겠습니다.
That is the tendency that is observed. This is because the implant body's design. This is more prone to get good primary stability. This is a major factor, and as mentioned, as the surface developments continues on, hydrophilic surface, biologic surface is developed, and secondary stability is increased, leading to better total stability. If the bone quality is weak, surgical techniques have been developed so that good primary stability can be achieved. Even if you place multiple implants in not so favorable bone condition, you can do cross-arch splinting on multiple implants prosthodontically. Therefore, you can get more favorable condition biomechanically. As we have come to have deeper biomechanic understanding, the loading period can become faster.
생역학적으로 이해도가 높아진 점도 이 로딩 타이밍을 조금 더 짧게, 조금 더 빨리 가져올 수 있는 그런 요인이 아닐까 그렇게 생각을 해봅니다.
Let's look at the decision criteria for immediate and early loading.
로딩을 하기 위한 어떤
If you look at the different criteria, the most important is primary stability.
이니셜 스테빌리티가 되겠습니다. 이 이니셜 스테빌리티가
If the ISQ value is over 70 and initial torque is over 35 newtons, then that is clinically favorable. If you look at the reference that I've mentioned earlier, the ISQ value is 60 to 65 and initial torque is 20 to 45 newton centimeter. However, clinically, I think we need to approach this more conservatively. If you want to do immediate loading, it needs to be over 70 and torque value needs to be over 35 newtons. I think this would be a safer way to go forward. Then what would be the cases where we need to consider conventional loading despite all of this? Immediate implant placement, the use of short implant or reduced diameter implant, if sinus elevation has been done, large bone defect, or if the patient has parafunctional habit.
그래프트를 했다든가 아니면 환자의 어떤 파라펑셔널 헤빗이 있다든가 이런 안 좋은 그런
Due to such negative factors, conventional loading needs to be done. That'll be the safer way to go.
할 수가 있겠습니다.
If you look at the timetable, applying load after 8 weeks is referred to as conventional loading. However, the period has become much quicker than what we've considered conventional in the past. If there has been a lot of bone graft or if the primary stability is bad, you can delay it by 1 or 2 months and do delayed loading. After 2 months, if you apply loading compared with the past,
2개월 이후에 로딩을 가한다고 하면
from implant placement to conventional loading, the time period is not very long. Therefore, if you want to go safer option,
때문에
I would recommend using very predictable conventional loading method. In partial edentulous case, if you are to place implants, even if you place implant in certain area, if normal function is possible in other areas, you not necessarily want to go with early loading or immediate loading, which has some risks. It's better to use conventional loading.
피해서 얼리 로딩이나 이미디어 로딩의 어떤 약간의 위험성을 꼭 감수할 필요는 없지 않을까 이렇게 생각을 합니다. 그리고
Also, in the case of upper posterior area with bad bone quality where early and immediate loading shows less success rate, and in the case where you have to submerge it because you have done GBR, naturally you would have to have conventional loading period because you need to do re-entry and secondary surgery. Next, I'm going to talk about how to do loading protocols with implant prosthesis. If you look at the ITI Consensus Conference report, In all clinical situations, including single implant to fully edentulous cases, from good bone quality to bad bone quality, in all clinical situations, conventional loading shows very predictable results. Conventional loading must be stick to if primary stability is not good and if there has been significant amount of bone graft done. Additionally, if you have used short or narrow implants, if you have used implants with reduced contact with host bone, or if the host has systemic disease, it is better to do conventional loading. Depending on clinical situation, let's look at the loading protocol to be used. Loading protocol for single implant, if you look at the upper and lower, it can be differentiated. Lower has better bone quality compared with upper. In the lower, immediate and early loading as well as conventional loading show comparatively predictable results. In the upper, as for immediate loading and early loading, these are not impossible, but evidence is not sufficient. In order to do immediate or early loading, you need to be aware of these precautions. As mentioned earlier, primary stability is utmost of importance. You need to take a more conservative approach compared to what is written in the literature. You need to get over 35 newtons of primary stability and over 70 of ISQ value. In the case of lower, you get 75 a lot, but you need to get at least a 70 or above to get immediate loading or early loading. In the case of anterior area or premolar area, you can get predictable results in terms of survival rate or marginal bone rate. However, in terms of gingival recession after implant placement, in terms of aesthetic parameter, it is not exactly predictable. If you divide upper and lower in that sense, in the lower, it may be predictable, but in the upper, it is not recommended to do immediate loading. This is an older case. Let me share with you a simple case. In 2006, the patient came in with a lot of damaged teeth. As mentioned, unless it is emergent case, if you wait 8 weeks after extraction, phase 1 bone regeneration is complete and soft tissue healing is done. It becomes very easy to do surgery as shown. Flap was reflected. Implant was placed, healing abutment was connected, one-stage surgery was done. You can see that woven bone was formed and simple surgery was done. After 6 weeks since one-step surgery, early loading can be done. After 6 weeks, a cementation type prosthesis was delivered. Let's look at another case. After extraction, if it is difficult to do early loading or immediate loading, you can use conventional loading routinely. After 2 or 3 months, loading is applied. In general, in this case, extraction was done. Soft tissue healing was waited for 2 months. After that, in number 17, sinus crestal approach was done, as well as sinus graft. A single implant restoration was done. After 3 months, because sinus graft was done, I waited slightly longer than 2 months. At 3rd month, I provided prosthesis. On X-ray, you can see stable conditions. In these 2 cases, conventional loading or early loading was proceeded, but if you look at the recall image on the left, it's been about 10 years, and on the right, it's been about 5 years. You can still see that the prosthesis is stable. It may not be really important to whether to do conventional loading, early loading, or immediate loading. In single cases, it's not that important because the patient can enjoy ordinary life with other teeth. We need to evaluate what gains we can get clinically and what risks there are.
권해드리고 싶습니다.
Let's move on to partially edentulous cases.
얘기가 달라지는데요. 발치를 하고
In healed ridge after extraction,
리치에서
you can get predictable results with conventional loading and early loading.
얼리 로딩까지
There is some basis with immediate loading, however, you need to strictly select cases following the protocol.
정확한 프로토콜을 지켜서 시행을
In the case of upper and lower anterior area, you can get predictable result with early loading, but if there are multiple missing teeth in the anterior area with immediate loading, there is still lack of evidence.
부족하다 이렇게 말씀드릴 수가 있겠습니다.
As is with conventional loading,
한 4주에서
early loading, which is done between 4th and 8th week, is predictable in most of the cases. In the case of immediate loading, as mentioned in the posterior area, in healed ridge after extraction, it is predictable, but depending on the scope, you need to see whether number 6 and 7 are the only teeth missing, or if there are extensive missing teeth, you need to weigh the gain and the risks of immediate loading. If there are many advantages you can get clinically, you can do it.
시행을 할 수가 있을 것 같습니다. 그리고 전체
However, in the case of anterior area, if there is extended missing area because there is lack of evidence, we need to be careful.
해야 될 것으로 생각을 하고요.
It is very important to get to primary stability when you do immediate loading. If there is bone graft involved or if the patient has systemic disease, you need to be careful in your approach, and the surgeon's skills may also play into the factor.
접근을 해야 되는 것이
This is a case we can see frequently in posterior area due to periodontitis. Extraction was done. You can see that all posterior are missing. In such case, we normally wait 6 to 8 weeks.
길게는 한
Soft tissue healing has been done nicely. Implants were placed.
그리고 나서
2 weeks were waited. Impression was taken and prosthesis was delivered. After about 3 months, custom abutment was delivered and prosthesis was provided.
고철물을 딜리버리하게 되는 기간까지 보통 한 2개월에서 3개월이 걸리게 되겠죠. 이런
This is a routine clinical process.
과정은
This is the most predictable and safe way to go forward.
그렇게 생각을 합니다.
On the other hand, in posterior area, when multiple teeth are missing,
어떤 임상적인 상황이
there are cases where you need to do immediate or early loading. For instance, in this case, in the upper and lower, multiple teeth are missing and additional extraction is required, but due to patient's requirement and due to clinical situation, the patient was wearing RPD in the upper and lower. If the patient removed the RPD on one side and did surgery on one side, you would have to make a temporary RPD again, and adjusting this will not be easy, so doing surgery on both sides at the same time and providing removable prosthesis within as soon as possible was required.
프로세스로 기능을 할 수 있게 해드리는 그런 게 필요한 그런 상황이 되겠습니다.
In this case, you need to evaluate the bone quality and bone amount first. You need to provide interim restoration.
레이션을 할 수 있는
If that is possible, immediate loading may be feasible.
적용을 해볼 수가 있겠습니다. 이 환자 같은 경우는
The patient was wearing RPD and implants were placed on both sides after 5 days. Actually, on the day of surgery, impression was taken, interim prosthesis was provided. After 5 days, temporary prosthesis was fabricated for both upper and lower. Immediate loading was done. Once temporary restorations are placed, the patient can chew using posterior teeth. After 4 to 5 months consecutively, prosthesis was delivered. In fully edentulous cases, placing multiple implants and splinting them in a cross-arched manner to get cross-arch stabilization, conventional loading as well as early and immediate loading is possible.
컨벤셔널 로딩은 물론이고 얼리 로딩
You can get predictable results even with immediate loading in this case.
을 하고 프로토콜이 적용이 된다면 이미
In fully edentulous patients, you can get predictable results in immediate loading as well as early and conventional loading. However,
로딩이나 컨벤셔널
this is possible only when you can provide one piece of fixed interim prosthesis.
다만 원피스로 만들어진 인테림 픽스 레스토레이션을 장착을 할 때 그것이 유효하다 이렇게 말씀을 드릴 수가 있겠습니다.
The recommendation is to check primary stability. You need to get over 30 newtons of insertion torque and over 60 of ISQ value.
60 이상을
Let's say when we place multiple implants and most implants have ISQ value of over 70 or 75 and insertion torque of 30 newtons. But if one or two are not over 30 newtons and if it is ISQ value of give or take 60, it is still okay because it is one-piece interim restoration. The dimension of the implant to be used should be over 10 millimeter. You need to look at these numbers. In the case of upper, if the residual bone is very thin, or if the patient has gone through extensive sinus lift and bone augmentation in that area, the immediate loading should not be done in that area. You need to be flexible.
제외를 하고 이미디어 로딩을 한다든가 그런 융통성을 발휘해야 될 것으로 생각을 합니다.
As shown in this case, in the case of lower, after placing implant, the temporary restoration was partially provided in the posterior and anterior regions. If you provide restorations in one piece, it can be difficult. So at first I made it into 3 pieces. I splinted it intraorally. In the case of upper, because the bone quality was not as good as the mandible, if some implants do not have as good primary stability, if most of them have good primary stability, you can make one piece provisional and submerge the areas where the implant primary stability is not so good. This could be an option. Except for such implants, interim restoration was provided and immediate loading can be done. The final prosthesis was provided, and after 6 years and 7 years, this is the X-ray image. You can see that marginal bone level and prosthesis is being maintained.
안정적으로 잘 유지되고 있는 것을 보실 수가 있겠습니다.
Finally, I'm going to talk about the decision of loading timing. There are multiple factors that determine loading timing. I've talked about implant stability. In the graph, how much and when the stability dip exists can play into the factor. You need to also look at bone density, whether there has been bone graft or not. You need to check whether the implant design is the type that you can get good primary stability. At the time of implant placement, primary stability is of utmost importance. After prosthesis is delivered and provisional is delivered, you need to check whether this is a single implant case or multiple implant case and whether cross-arch stabilization has been achieved. You need to look at occlusal force, and if the patient has a severe parafunctional force, you need to take that into your consideration as well. The timing for delivering implanted prosthesis, these factors need to be considered. In order to determine loading timing, from diagnostic stage and surgical stage and prosthodontic stage, there are different timings in different stages where we can anticipate the timing of loading. Before surgery, CT image needs to be checked to anticipate bone density. Upon surgery, when you drill and the amount of torque that occurs when you actually do placement, you can anticipate or determine whether to do immediate loading or early loading. Once the surgery is done, RFA analysis can be done. ISQ value needs to be measured so that you can get a sense as to how much contact the implant has with the bone. You need to determine that before determining loading timing. X-ray image needs to be taken before surgery to check whether immediate loading is possible. And depending on bone density, you need to look at the Hounsfield unit. The water has a 0 Hounsfield unit value, NML, which has the biggest radial opacity, is about 2,500 to 3,000. The trabecular bone or cortical bone is about 150 to 900 and 900 to 1,800. Clinically speaking, we divide bone quality into D1, D2, D3, and D4. If you look at D2, the Hounsfield unit value is about 1,000. D3 is about 500. Clinically speaking, let's take a look. CT is taken in the area where implant needs to be placed. The sectional inspection is done, and if you anticipate the Hounsfield unit value on top, upper anterior, and upper posterior area, if you look at the different Hounsfield unit value, if you were to place implant here in the maxilla, if you look at the numbers on the left, it shows about 1,000. From 750 to 1,000. If the value is like this, if you place implant here, the bone quality is like D2, so you can get good primary stability, and therefore immediate loading or early loading may be possible. This can be deduced. If you look at this graph, if you position the implant in the buccolingual side, the Hounsfield unit value is about 1,000, and the upper posterior area where bone quality is very bad, you can see very low values. In the case of upper posterior, immediate loading is not possible. Conventional loading or delayed loading needs to be done. Such plans can be made ahead. You can get a better sense when you do implant placement. When you open flap and drill and place the implant, you get the tactile sense of the bone quality, whether it is D1, D2, D3, or D4. You can see it as well. And upon implant placement, you can check how much Newton you get with insertion torque. You can gather these informations, and based on that, you can determine the loading period, whether the bone quality falls under D1, D2, D3, or D4, and if the insertion torque is 30 or below. You need to set the implant placement engine program ahead, and you need to mark whether it falls into which category using 20 or 35 as criteria. This will be of great help in determining the loading timing. So let's see here. I write 2-3 or 2-2. In the front is bone quality and the back is initial torque. And then I mark about the bone quality regarding 1, 2, 3, 4. 0 to 3, it has been divided. 20 Newton is used as criteria, whether it is below 20 Newtons or if it is between 20 to 30 Newtons or over 35 Newtons. If you mark this, let's say if the patient has type 2 bone quality and has over 3 primary stability value, this can be used as a standard to determine whether to do early or immediate loading. If the primary stability is over 3, if you convert that to ISQ, it is over 70, therefore immediate loading can be done. The minimal condition for immediate loading can be secured. ISQ value. After surgery is done, in determining when to load the prosthesis, the ISQ value can be very useful. Resonance frequency analysis is used. This is used to measure ISQ value. On average, the values range from 1 to 100 after implant placement. Normally, it is between 60 and 90. If the value is lower than 60, the implant bone quality may be very bad or implant may be failing. You can consider that as ailing implant. If the ISQ value is between 60 and 70, at times you can split multiple implants and gradually deliver prosthesis in 2 stages. Or if it is between 65 and 70, you can do early loading or conventional loading. If it goes beyond 70, then you're in the safe zone. In single implant cases, you can do immediate loading or early loading. ISQ value is non-invasive to the patient and you can measure it repeatedly. So this is a value that has a lot of credibility. It is the only way to record how much osseointegration has been achieved in a quantifiable manner. This is something that I use very frequently clinically. If the value is 75, You cannot trust it 100%. You need to measure it continuously and check the tendency whether it is improving or is decreasing. The tendency needs to be checked. In the past, in the first generation OSSTEM, the receiver was connected directly to the implant body. It was wired type, so it was very tedious to use, but now the third generation is wireless type. Now, the fourth generation pen type has been developed, so you can measure in a wireless manner, in a repeated manner. It is non-invasive and it is a very useful tool to determine loading timing.
임플란트에 어떤 인베이시브한 그런 트라우마를 주지 않으면서 측정을 할 수 있어서 로딩 시기를 결정하는데 굉장히 유용한 툴이라고 할 수가 있겠습니다.
Pre-op, CT Hounds field value. And during surgery, you can check the bone quality or primary stability. After surgery, you need to look at the ISQ value to determine the loading period. Additionally, you can use clinical examination. For example, you can do percussion test as well as mobility test. On the X-ray image, you need to look whether there's radiolucency between implant and bone. Also, you can use perio test on the healing abutment and check the level of movement. There are different ways to check, but it does come with its own set of disadvantages. Rather than being able to check quantifiably, you can only check whether it has failed or not. In the case of perio test, which looks at ISQ value, the predictability falls compared to OSSTEM. And in the posterior area, the axis is limited because vertical force needs to be applied to the implant. Let me share with you a final case. If you look at this ISQ value, this is something I use very frequently clinically. The patient was using RPD on both sides of posterior area because the patient did not have sufficient bone volume. Some implants were placed in a simple manner, but in the posterior area, ridge split needed to be done. When I measured ISQ value, the two mesial implants had higher value, but in the case of two distal implants, the value was not high. The ISQ value objectively evaluates how much contact the implant has with the bone, and you can see in the figures 57, 62, and 58, they're very low. After surgery, we had about 3.5 months of healing, and when I measured ISQ value once again, as you can see, it has improved to 83, 84, 78, and 81. You can see that with these numbers, osseointegration has occurred nicely. You can indirectly check that the contact between implant and bone has been improved. The prosthesis was delivered in the case of the other side. Ridge split was done more extensively, and naturally, the contact between implant and bone was very limited. The bone quality was not bad, except for number 4, which is the most mesial implant. The number 5, 6, and 7 show very low primary stability in 1s and 0. Horizontal bone augmentation was required. A GBR was done, and it was submerged. Re-entry was done. After that, 4.5 months later, ISQ value was measured, 83, 81, 83, 82. You can see good ISQ values here. After that, final prosthesis was delivered. This is after 9 years on X-ray image and clinical image. You can see that after having achieved a good ISQ value, final loading was done and good results were achieved. ISQ value is a very important objective criteria in determining when to do loading. Today I talked about type of implant loading protocols of implant prosthesis for different clinical situations. And I've also talked about decision of loading timing before, during, and after surgery. In today's lecture, I talked about the different types of loading timing and the application clinically. I hope today's lecture helped you in determining the appropriate loading period and use appropriate tools.
조금이나마 도움이 되셨으면 합니다. 경청해 주신 여러분
Thank you for watching.
감사합니다.